Good evening, guys. Please take your seats. I think most of us are in the room, and few of us who are in the auditorium outside could please join us. And we are about to begin. We are running a few minutes late, and we definitely want to not make it a very late night for all of us, though I'm sure we have an engaging lineup. So this is the 5th Dallas Cardiovascular Innovations meeting, and I have to absolutely say that this would not be possible without the support of each one of you, the Dallas community, people from all over Texas, Oklahoma, Arkansas, and all of esteemed faculty who have come from distant places in the country. I also want to thank the sponsors and for supporting this event, and I hope that you will engage us in a Q&A that's going to be with the panel and also after each presentation. So with that, I'll kick it off, and I want to have my partner, Brilakis, say a few words about this special occasion, what we are commemorating today as part of Dallas CVI 2015. So welcome all.
Thank you, Subhash. So as you all know, this past year we did have a tragic loss from our department. Dr. Owen Nobel, our electrophysiologist for 11 years, since 2004, unfortunately died late last year. As you know him, he was an amazing physician, an amazing friend, an amazing colleague that we all miss very much. So the meeting is dedicated to his memory. Dr. Richard Wu, one of his close friends and electrophysiologist as well, will give a memorial lecture tomorrow morning. But if you can just join me for 15 seconds of silence in his memory, he is always going to be remembered by us, and we'll feel his absence every single day.
I am the introduction to an amazing lineup of cases that you will see. To put that in context, I want to present you the issue of the topic of complex and higher risk indicated patient. It is currently being talked about in the interventional and cardiovascular community. And I think I want to outline this for you so that you can enjoy the content that is going to be presented after me. Okay, so let's leave it here, and I will try my best to take you through this. So the kind of patients we are talking about have fallen into 3 very large categories. Patients with complex coronary anatomy, that is indicated by the blue sphere. The patients with hemodynamic compromise, that are patients with depressed LV systolic function and advanced heart failures. And also patient comorbid conditions, and they are all listed here, and most of you know these patients. Patients with severe complex vascular disease, patients who have had prior advanced heart failure, patients who have had a recent non-cardiac surgical procedure, or recent acute coronary syndrome events that all put them in a high-risk category. So I think the concept of indicated and high-risk patient is substantiated by this slide. If you follow the block on the left, that includes patients with advanced heart failure symptoms on the y-axis and complexity of coronary artery disease on the x-axis. And to the right is the block with a similar scheme indicating patients with anginal symptoms. And the issue of protected PCI refers to the highlighted section in yellow, which shows that based upon the current published appropriateness guidelines, treating these patients percutaneously, if bypass surgery and other options are not available, would be indicated and appropriate. So every patient who has a high-risk anatomy and comorbid condition does not fall into the category where we probably have no options for them. However, there are situations where, as indicated on the past slide, that those patients could be appropriately treated. So what decides the revascularization strategy by risk category of patients? You will see a lot of advanced techniques from many of our presenters who will follow me after this presentation. However, if you follow the scheme, the simplest way to think about this are patients with an anatomic risk on the y-axis is again low, medium, and high, and surgical risk, low, medium, and high, are those patients who may or may not be able to have a PCI. So if they have a high surgical risk but a low anatomic risk, For example, you're dealing with a bifurcation or a tiny distal LAD, you may not need a hemodynamic support device to support that patient through that very intense procedure. However, like many of you may have seen this morning, we did a case of patient with heart failure symptoms, overall preserved EF, but very difficult targets and a left main disease heavily calcified, and that patient appropriately would fall into the category of high risk at the very bottom and right of the screen, and supported PCI with a hemodynamic device would be extremely essential and be valuable. So when I say about hemodynamic support, what do I really mean? So I'm mainly referring to devices because the one on the far left is truly not a hemodynamic support agent. It could increase your blood pressure, if that is the metric, but it overall increases myocardial oxygen consumption. And that's the measure of efficiency of the heart. So it is not really a device that could be considered a hemodynamic support device. However, if you consider devices and interventions that actually unload the left ventricle, there is most commonly used 3 devices I just mentioned. There are a few more, but ones that people use in the cath lab is the intra-aortic balloon pump, the Impella percutaneous device, and of course the tandem heart that is often used in specialized centers. I cannot give you a full breadth of each of these devices, but I can mention it very briefly. The tandem heart recovers blood from the left atrium, oxygenated blood from the left atrium, and diverts it to an external pump and pumps it back into the arterial system. So what did it really do? It took oxygenated blood from the left atrium, gave a complete rest to the left ventricle, and injected that blood back into the circulatory system. It requires, as you can see, a transeptal procedure where you have to go from the venous side into the right atrium to put the cannula through the interatrial septum into the left atrium. That can be sometimes technically challenging. We have done very few of these cases, but mainly this is currently in clinical practice and been replaced by a much more effective and easier to use device called the Impella, which is a very simple device. It's like a pigtail catheter that you insert through the femoral arterial system or other arterial systems and place it across the aortic valve into the left ventricle and partially into the ascending aorta. The Impella has an inlet port which draws blood from the left ventricle and through an axial motor deposits it into the ascending aorta. So it simply unloads the ventricle and delivers blood into the ascending aorta, which then feeds the entire systemic circulation and also the coronary arteries. This very short video, which I may cut it out after the key part, just to save some time, demonstrates the placement of the Impella catheter. As you can see, it is placed like a pigtail catheter. The inlet port is in the left ventricle. This is the aortic valve, and the outlet port is in the ascending aorta. There are many other technical details and specifications about placing this device, but one of the most important issues while this video plays is dealing with the vascular access, and we generally use a pre-closure device, a suture, that allows us to achieve hemostasis after the device is retrieved from the body. So it's a very simple device, and I think it has really helped in transforming percutaneous care in the cath lab. We can move on to the next slide. Based upon a lot of data presented, and many of them from observational registries and also from one randomized trial, the Impella 2.5 has been approved, has an FDA indication for ventricular support in indicated high-risk percutaneous coronary intervention cases when the case can be either elective or urgent in hemodynamically stable patients with severe coronary artery disease and depressed LV function, when a heart team has actually discussed the appropriateness of its intervention. I want to underline that word, that whether something is appropriate or inappropriate is a collective decision. This is what we have done traditionally, and I think that needs to be pursued and aggressively practiced before such devices and such technologies could be used in everyday practice. Impella, as I said, has shown that it reduces major adverse events. This comes from the summary slide of the PROTECT 2 trial. There was no difference at 30 days between the Impella and the intra-aortic balloon pump. This was a randomized study in terms of major adverse events, but at 90 days, there was a statistically significant difference, again, extrapolated and shown on this Kaplan-Meier event curve. So this is major adverse event showing reduction at 90 days. So what does Impella actually do? It did show that in the study it improved systolic pressure, improved diastolic pressure, and most importantly, improved mean arterial pressure that actually determines perfusion of end organs in our body. This is probably an important concept that I think will be repeated over and over this evening, that the benefit was seen greater with greater severity of coronary artery disease. If you look at patients, this is procedural decrease in arterial pressure from baseline. The yellow is the Impella, less decrease and greater benefit with 3-vessel disease compared to 1-vessel disease. So I think all of them are statistically significant. However, the benefit might be greater realized in more advanced cases of coronary artery disease. Again, based upon the data I showed you, the major adverse cardiovascular events were reduced, and more complete revascularization was performed when the operator had the luxury and the comfort of the patient being stable through the procedure when complex coronary anatomy was being treated. And again, this translated into a greater number of cases with complete revascularization with reduction in major adverse cardiovascular event. Again, not much difference when Impella or IABP or balloon pump was used with 1-vessel disease, but again, the differences are realized when more advanced and complete revascularization is performed. It does improve LVEF. This has been shown by multiple registries and studies, and those are all displayed here. One of the most important ones that we participated in is the US Impella study and the PROTECT 2, and both of them did show a statistically significant improvement in not only EF, but also heart failure symptoms. Again, the green shows less advanced heart failure. It was very few patients, and post-treatment at 90 days, most of our patients did have improvement in their heart failure symptoms. Cost effectiveness. It is an important question, when to remove the Impella. Most of the cases were removed, the device was removed after the end of the procedure. You did not need to support those patients in the ICUs for days. That sometimes we see when we treat such patients with not hemodynamic support used in the right way. And therefore, if you reduce length of stay, you do reduce overall outcomes, you do reduce readmission rates and need for repeat procedures as indicated on this slide, and those all combine to give us the cost effectiveness and the cost benefit of using the device, because there is an upfront cost of using this device. There's also a very important question that always comes up, is the risk of rate of vascular complication. And these are data from the IABP arm and the Impella protected patients from the Impella safety endpoint studies, which is a combination of PROTECT 2 and the Impella registry. And as you can see, the overall major vascular complication rate was 1.4%. Minor, which is not shown here, is between 5 to 7%. I want to end this and show you a very quick case. This is a patient who is a diabetic, fairly young, non-STEMI, had ongoing hypotension with low EF and presented with also non-sustained VT. His distal left main and his LAD. This is his graft. As you watch this graph, please pay attention. I tried to cut out the number of videos I was supposed to show, but there was severe disease from lima to LAD involving the anastomosis. So I think the indication was to treat the native disease. So keep going forward. This is his femoral axis. You can see the right side has a major severe disease, and the left is actually quite patent. The Impella was placed from the left side, and the right side was first stented and then treated. And this patient underwent a lima to LAD first stage, and then following a left main to diagonal intervention at a subsequent stage. I'm going to just show you the lima to LAD intervention today. It was pre-dilated with a balloon. It was done with a 2.5 millimeter Impella support. The patient remained completely hemodynamically stable, and this procedure was completed. Actually, Rick, if you remember, this was the last Dallas CVI case that we did live last year. The right iliac artery was stented, and we always take pictures after the Impella is removed, and it shows good flow, and after post-closure. And this is another case. I'm going to stop here because I've taken too much time. I don't want to take up time from my other speakers, but I'll keep this for a later day. And I appreciate you bearing with me with all the technical difficulties. Hopefully by now everything is fixed and the other colleagues and guest speakers would not have the trouble. So thank you very much, and thank you for being here.